I'll be speaking about my experience with the fibrin glue for complex retinal detachments when silicone oil is also injected. This has not been described actually. At the time we started doing this, it was used only for some simple rhegmatogenous retinal detachments to avoid the use of oil and gas. But we have used it with oil for complex detachments. Okay. So as I said, it has been used earlier for simple detachments to avoid the use of oil or gas, but not reported for complex detachments with oil injection. So 2 years back we were faced with a situation, a PDR combined RD which did not settle because there was an open break superior to the macula. We attempted resurgery, tried to do membrane peeling around this hole and aspirated the SRF, but the hole did not close, and so it was not amenable to laser. So we instilled some glue over the break, and to our surprise the detachment very rapidly attached without the need for much of positioning. And this is the patient 2 years back who is still doing well. The oil is not emulsified. IOP was never high, no inflammation, retina stable. We removed the oil a few weeks back and the patient is doing well. This is a very recent patient. We have used for several cases. This one very recent, PDR combined RD after complete membrane peeling. At the end there was a break which was not amenable to laser, as you see. We tried to do, it's not showing there, I'm sorry, the video is not running there.
Double click करो.
Okay, I'll try again.
Video देखिए.
Video is not playing.
Video.
It's playing on my computer. But okay, let's move on. So there was a break which was not amenable to laser. So if you see the white, that is the fibrin glue, that is where glue was instilled over the break. And you can see on day 1 retina was attached. And this glue resolved within a few days. And this was operated a few months back. Patient is doing very well. No complications from the glue. Another patient, again the video not running. This is a PDR. As we did extensive membrane peeling, there was a break superior to the macula, again not amenable to laser. So we injected 2 components of glue over the break, and you can see very rapidly the retina was attached, and you saw the pre-retinal picture was, pre-surgery picture was very bad. You saw the membranes, and you see now it was very good, and this is more than a year back. Patient is still doing very well, no complications. Again the video not running, I'm sorry. Here the break was close to the macula after the membrane peeling. So again we didn't want to do laser close to the macula. So fibrin glue was injected over the breaks, and that's bad. So this was showing, the video itself shows the post-operative course, which was very good. So we extended the indications to non-diabetic complex detachments, which included macular hole RDs, where you cannot do laser for the macular hole. And you can see in this patient, this was a thrice operated RD. There was no ILM because it had been removed. So we put glue over the hole, and very rapidly, 5th post-op day, the retina is nicely attached, macular hole is closed. And that was the glue. Again, young boy with an RD, macular hole was the only break, causative break. We did a drainage in a mid-peripheral location and then instilled glue over the macular hole. Again, the video is running on my computer, so that's okay. But if you see the 6th post-op day itself, you can see the glue closing the hole. On the 10th post-op day, the macular hole is closed, the retina is attached, and again this is more than a year back, 1.5 years back. Patient is still doing well with oil in situ. Sometimes the hole may not close, but the macular hole RD will settle, and that itself is good because at least the patient regains most of the peripheral vision, like in this patient. And in this patient, 3 times operated for macular hole, failed, but in addition he developed a retinal detachment, so we saw him at this stage. So during surgery, again the video not working there, during surgery we attached the retina with and then put glue over over the macular hole only. And you can see that the first post-op day itself, the retina is attached, the glue is closing the macular hole, and after some days, the hole is still open, but the retina is attached, and here you see subretinal glue, which is a very important thing to understand. This can cause some loss of visual function. So the tips for techniques is that the needle tip blockage is very common with this glue. So just before entering the eye, we must check that the needle is not blocked, because if you go inside and try to open the block by forcing it, it enlarges the retinal break because it comes as a jet, and it also causes excessive injection. Now the glue, the two components of glue which are injected one by one are both transparent, and even when they mix together they remain transparent for some time. So it's very common for us to go on injecting because we cannot see what we have injected. So we have to be vigilant to avoid over excessive injection. I found that 2 cc syringes are better than 1 cc syringe because they are smaller, so easy to handle, and the blue one should be used first because it's more viscous. Subretinal glue is seen as you see here, and that can cause atrophy. So if it's a macular hole situation, we should be careful. There may be a loss of vision because of the submacular exudation. Even in peripheral breaks, excessive injection can cause the break to remain open, and there can be a failed RD which we had to reoperate to attach the retina. So in summary, fibrin glue can be a very useful adjunct in the management of complex RDs where laser cannot be done due to bleeding, retinal edema, persistent SRF, or proximity of break to the center, or macular hole RD. It causes rapid retinal reattachment compared to silicone oil surgery alone, and the need for post-op positioning is reduced because now the break is closed on the table. We do not need silicone oil to positioning to close the break. And we have not seen any long-term adverse effects with silicone oil in situ. Thank you.
Thank you.
Is my time up?
Doctor, I believe, is it your meticulous removal of membranes working, or is it the glue which is working?
See, meticulous membrane removal is anyway required. Without that, even glue will fail because the break will remain open from the traction. So that has to be done, but when laser is not possible, then this is being used.
So the glue is causing a sterile.
No, it is actually physically, mechanically plugging it. It's like going and putting something to seal the break so that the SRF does not accumulate again, and the break is closed immediately.
More than anything, I would just like to learn from you. Ma'am, I just wanted to ask, do you decide on table that you will be using fibrin glue in this patient?
Yes.
Or is it like a pre-operative?
No, generally on the table when we fail with our laser, there has been bleeding or SRF is not going away, on the table, usually on the table.
Okay, and otherwise when you have these really bad detachments which have bands, subretinal bands, so is that, do you sort of have to remove the bands, or does it work with the bands, and will it just sort of physically stop it and put it down?
See, again, the criteria for removing bands will not change because of glue. You will still remove if you feel that the break is going to have a traction because of your bands, or the retina is going to be elevated because. So irrespective of glue or laser, you will still do your membrane removal or subretinal bands removal as you would do in any other case. Then you take the decision for glue only when the break is not closing, or your laser is not possible. Or laser is not happening basically. I'm sorry, none of the videos ran. I'm very, very sorry, but